When I was in our Gambrels location earlier this week, we had an individual coming in for a frozen shoulder. And the frozen shoulder diagnosis, it's always an interesting one because they tend to happen one of two ways. It's either the insidious onset, where there's no traumatic mechanism, there's really no specific thing that brought it on, it just slowly, gradually, insidiously builds. Then you have the other type of individual that maybe they did have a trauma or they did have some sort of provocative incident. So maybe they had a surgery, and because of the pain of the surgery or because of maybe the sling that they were in and just immobilizing the area, they end up developing a frozen shoulder after that. Or maybe they had a secondary shoulder injury. Maybe they have a bursitis, maybe they have a rotator cuff tear or labrum tear, and they're inadvertently not using that arm as much, and they're not taking that arm through a full range of motion, so they end up developing a more stiff shoulder that then gets diagnosed as a frozen shoulder. The other thing that I've seen is some individuals get diagnosed with the frozen shoulder, but it's less that they've actually had a true stiffening and inflammatory process that's taken place. They're just extremely apprehensive to utilize it, and they're just presenting with a shoulder that appears to be more stiff than what it really is. And that's probably due to a secondary shoulder injury that they've sustained, maybe an underlying rotator cuff tear, labrum tear, tendinopathy or bursitis, something that is truly painful and mechanically limiting. But because they're guarding so much, you cannot get them into those testing positions to rule out and tease out how much of this is really a frozen shoulder, how much of it's a tendinopathy, how much of it's a rotator cuff tear. But the reason I bring that up is your treatment approach and more importantly, the exercises you should select for this person should match up with what you are finding from an evaluation standpoint and from their overall mechanism of what's caused them to present that way. Now, I've had people in the past that if they have a true frozen shoulder, meaning they've got an inflamed joint capsule, they have just global stiffness that follows a capsular pattern, and I've seen myself and other PTs in the past try to put them into a position that's overly complex or overly difficult to get into or execute. So maybe they have an unstable object that they're utilizing to help mobilize the arm, or maybe they have the individual getting into a position that's just difficult to achieve, and because of the complexity or just the nuance of that activity, they're unable to even provide a stimulus that's going to give them the desired stretch that they want. So an example of this is I had the PT I was working with was having the patient do almost like a TRX walkout or a walkthrough, where they would stand with the TRX in their hands, they would walk forward, and as they walked forward, they would let the TRX go up and over. Now, the hard part with this is there's a lot of moving pieces to that, and the individual themselves needs to be able to let the shoulder relax as they walk forward, handle the position of the TRX. Now, the beauty of the TRX is it provides a lot of degrees of freedom and a lot of variability with movement, but the individual still needs to be able to be mindful of that and control that movement to get the desired stretch that they want. And the individual only had about 100 degrees of shoulder flexion anyways, so we were never able to get them into the position to get up and overhead enough to utilize that force that we wanted with the TRX and their body position to pull their body through and get the arm overhead. So what we ended up opting for instead was still staying in the rig and the rack that we were at, but holding on to the barbell, having them have a fixed hand position on a fixed object, and then be able to lean back. So putting their hips behind them, giving them the cue as the hips go back, the head and shoulders go forward, almost like you're trying to kiss the ground. And essentially the arm is staying still, but because they're moving their body, they're getting into relative shoulder flexion. The other advantage of that is all they have to do is lean back, and they can control how much of a stretch they're getting, how much stimulus it is. Because they're holding on to something, they're also getting distraction of the shoulder as well, which is going to be great for just a general global capsular stretch. And because they're holding on to a fixed object, they can get a little bit more leverage behind it too. I also liked that because it had the added benefit of being something they could translate to a home program by putting their hands in something as simple as a kitchen sink. So both stretches were geared towards achieving overhead range of motion, but for this individual who truly had just a very, very stiff shoulder and not as much body awareness, it was difficult for them to achieve it via the TRX walkthrough, which is a stretch that I do like. It just wasn't the most appropriate one for this condition. So when we're dealing with frozen shoulder, I think we need to look at how much of the range of motion restriction is coming from true capsular restrictions versus how much may just be fear avoidance and guarding, which comes down to you making sure you're putting them in positions to be successful, and how much of it may be coming from the surrounding soft tissue, deltoid, pec, lat, teres, some of the other muscles in that area that because they have not gone through their full range of motion for a period of time, they may be presenting with a little bit more tone or a little bit more tension than what they normally would as well. And I think having a good understanding of if we're going after the joint capsule, the tissue itself, or just the patient and their willingness to put themselves in position, it's going to allow you to better optimize what you're choosing from an exercise standpoint. Things that I've found myself keeping in mind with frozen shoulders is being mindful of, is this an open chain or a closed chain activity? And does the benefits of doing something open or closed chain put them in a better position for success? Also trying to utilize distraction whenever we can. And being able to distract the joint may give them a little bit more comfort and a little bit more freedom of motion to then tease into the different positions that you're trying to accomplish. Also, are we going through something that is more of a single joint or single plane stretch versus a multi-joint or multi-plane stretch? And this was a conversation I had with an individual too, where they struggled to get into this combined motion of shoulder elevation, abduction, and external rotation. And we were trying to do just a standard pec stretch for them, or trying to get them into a externally rotated position with the shoulder is what was expressed as the goal for that. And that's a great stretch, but unfortunately they didn't have the combined motions of elevation, abduction, and ER to get into it. So I'd also dug a little bit deeper and we talked about, well, we are also trying to get just some anterior mobility of the joint capsule and some more anterior translation of the humeral head and the glenoid. And we talked about, all right, well, we can do that through ER, but what are some other ways we can also accomplish that? And we mentioned horizontal abduction and also extension of the shoulder. So that was where we then regressed that exercise back. Instead of going into a full-on pec or 90-90 ER stretch, we then allowed them to say, hey, let's get rid of external rotation. Let's just extend the arm out and we can put them in a little bit more neutral hand as opposed to being externally rotated. And let's try to get that horizontal abduction as optimal as we can. And we had them hold on to an object, use trunk rotation away from the arm to facilitate horizontal abduction and an anterior translation of that humeral head. So having an appreciation of the intended joint mechanics that you're going for as well, you can find positions that are synergistic to the one that you're trying to achieve, but maybe tolerated a little bit better just by removing the amount of degrees of freedom or planes of motion or joints in play that you're trying to go after. So I think with frozen shoulder, what I tend to try to do is go into it almost with like a laundry list of potential exercises that you can do. Pick the one that you think they're going to best tolerate. And then with that exercise, define what are the qualities of this activity. Is it open or closed chain? Is it single or multi-joint? Is it single or multi-plane? Is it compressive or distractive in nature? Is it more dynamic versus a static, long duration hold? And if that exercise doesn't work, let's try another one in that category, but just a different exercise altogether and see if we can get a different benefit. If that one doesn't work as well, maybe we're just going after the wrong bucket or the wrong category and we need to switch gears into something else. So frozen shoulder, I think they can be a lot of fun to work with. Try to tease out the exact origin of what's limiting them or what's most limiting for them from a range of motion standpoint, soft tissue, pain versus a true capsular restriction. and then bucket your interventions into the different categories and qualities that those interventions possess, and then try to progress from there. But I think frozen shoulder is one that we can oftentimes just tend to go through the motions with. You have your go-to 5 or 6 stretches that you like, and I think if you go at it with a little bit more intention and a little bit more strategy, it'll allow you to allocate what activities can this individual just kind of do mindlessly at home and knock out repetitions and volume with, versus which ones do you want to be a little bit more nuanced in with the clinic, or leverage some time on the table doing hands-on techniques that they cannot accomplish on their own as well. And then one final piece to this, which I'm actually really glad this individual was able to, the PT I was working with was able to bring up, was just the appropriateness of maintaining activity levels with this individual and finding ways for them to stay active in the gym with exercises that fit within their tolerance and their movement availability. So with this individual, because they had the ability to get over 90 degrees, the PT I was working with, he was able to brainstorm a 6-station circuit for them to go through that included different pressing and rowing variations. We talked about doing a push-up from an elevated surface. We talked about doing an inverted row using the TRX, going over and doing seated rows, using the cable column to do a single arm rotational low row, and then also doing just bicep and tricep work too. And with all those activities, we're maintaining an active status with the individual. We're limiting the deconditioning effect with them. We're hopefully desensitizing and limiting some of their apprehension to just movement and physical activity in general. And the other sneaky thing that you're doing is if you have 6 different activities that you're doing, and let's just use an arbitrary number of 10 repetitions per activity, and you do 3 sets of that, that's an additional 180 repetitions of movement that you're going to have that shoulder go through, that is going to just add to more volume of movement, which we've already generally appreciated that kind of movement is medicine for these types of activities or for these types of pathologies. And the more general movement we can get, the better we can get that joint surface moving, tolerance to it, and it's just a sneaky way to get exercise reps in that also double as rehab reps.